All right. Hello, everyone, and thank you for joining us this evening as we kick off our new monthly Let's Talk series featuring experts we trust to share, educate, and discuss all things advanced care planning. My name is Josh Nelson. I'm the AmeriCorps Outreach Coordinator for the Fox Valley Advanced Care Planning Partnership. So if you're new to us or you're unfamiliar with our work, what is Let's Talk Fox Valley? Let's Talk Fox Valley is sponsored by the Fox Valley Advanced Care Planning Partnership. And it's a community movement to improve end-of-life care and encourage advanced care conversations and planning. So as we begin the Let's Talk series, I'll get into a little bit of intro on our speaker today that we have. So he obtained his medical degree from the University of Ibadan, Nigeria, and completed the Physician Executive MBA program of the University of Tennessee, Knoxville. He is board certified in hospice and palliative medicine and was the regional medical director of palliative care for Ascension based in Appleton up until April of 2020. He currently works with Ascension in Tulsa, Oklahoma, and also serves on the African Heritage Board based in Appleton, Wisconsin. He has a very diverse experience working in various hospital and healthcare settings in Africa, the Caribbean, and in the US with skills in inpatient care, critical care, medical education, and pain management. These have built a solid foundation for his expertise in providing compassionate palliative care for patients experiencing pain, debilitating symptoms due to chronic, complex, and life-threatening illnesses. Without further ado, it is my pleasure to introduce our speaker today, Dr. Olumuyiwa Adeboye. Doctor, the floor is yours.
Thank you very much, Josh, for that great introduction, and good evening, everyone. I meant this to be kind of like an informal conversation, just talking about what hospice and palliative care is all about. And I hope you can all see my screen. I've decided to kind of just put this together kind of as a brief discussion about what hospice and palliative care is all about. It's 2021, and this is an ever evolving and ever stagnant, should I say, question. What is hospice? What is palliative care? What's the difference? A few questions have been sent in, so I'm hoping that, we can kind of just address this and kind of talk about things a little bit like this, the session suggests. So starting off, I went to my dear friend Merriam-Webster, kind of just breaking down the definitions of both words. We'll start off with hospice. It says the first known use of the word hospice was over 200 years ago, 1818. Comes from the Latin word hospitium, which got translated into French. It says Middle French, hospice with an S, and then the English took it up and it became the word hospice. Hospitium in the Latin suggests hospitality, lodgings. It says monastic guest house, shelter maintained by a religious order for the poor and infirm. Now, I think this is why when you mention hospice to a lot of people, they think it's a place. It could be a place, but when you actually talk about hospice, it's more about the philosophy of care. And as you can see, I use this clipboard here, kind of showing all kinds of things that might be related to hospice, caring, supporting, and things like that. There's a lot of hearts here, showing that a lot of people with good hearts work in hospice. Then palliative. So it comes from the Roman word pallium, which it says is the Roman name for a cloak-like garb that was worn by the Greeks, which is differentiated from the toga. And that's why I kind of put this on there. Then from the Greek word pallium or Roman word pallium, it went into palliate. And to palliate means to lessen the intensity of a disease. So when you think of palliating something, you're kind of trying to make things better, or another word is ameliorate. The word recently, though, has kind of been used in a bunch of different terms, especially where I come from right now in the last year. There's been a lot of talk about handing out palliatives, which were kind of like means of lessening the impact of the COVID-19 situation for people. So the government was handing out what they called palliatives, which were kind of like all food stuff and things like that. Back to my dear friend Miriam, again, Merriam-Webster. If you see the word palliate, it tells you there it's to ease symptoms without curing the underlying disease. All right. So when you talk of palliative care, you know, what you're talking about is making something better. I put this there kind of just as a break, that kind of like when you say palliative care provider is a palliative care specialist, I think this is why people don't want to refer people to palliative care because they see this cloak and dagger situation. That's not always the scenario though. So we've gone through those definitions. I hope it's kind of helped at least provide some intro into what we're going to be looking at. Now, as far back as 2000, I think 10 or 11, CAPC, also known as the Center to Advance Palliative Care based in New York, carried out a study kind of trying to get what they described as an evidence-based definition of palliative care out there to a lot of people. When you ask people what palliative care is, a lot of people kind of are not sure. You hear palliative, 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 you know, and that's kind of why I went into that whole thing of kind of getting the definition out there. So what they did was interview people, providers, patients, families, and give them what the known definition was, and then ask them what they wanted to hear. So they put together this definition, which if you go on any organization's website, I can assure you this is what you will find there. Palliative care is specialized medical care for people living with a serious illness. It is focused on providing relief from the symptoms and stress of the illness. The goal is to improve quality of life for both the patient and the family. Palliative care is provided by a team of doctors, nurses, and other specialists who work together with the patient's other doctors to provide an extra layer of support. It is appropriate at any age and at any stage in an illness, and it can be provided along with curative treatment. Palliative care is based on need, not prognosis. And I'll try and take this and hopefully try and break it down in a way that makes sense as we go along right now. So we'll start off. Now, like we said, serious illness, all right? What is a serious illness? And then relief from symptoms. So we'll start off with those two phrases right there. Now, this is a nice graphic that comes from this article from the New England Journal from like 6-7 years ago. And I like it and I use it a lot because what they did was they took a look at the bottom of the graph there, cancer, congestive heart failure, COPD, CKD or chronic kidney disease, dementia, AIDS. These are examples of serious illnesses. Just some, not all. You can think of other things. Things that are not included here include things like multiple sclerosis, ALS, strokes, and things like that. Now, what they did was they looked at a whole bunch of different studies and kind of looked at what symptoms here in this box on the right are common across all these serious illnesses. And you can see all those symptoms. So when we go back to this definition here, serious illness and symptoms, these are the things we're talking about. These are examples of what we're talking about. So pain, breathlessness, fatigue, anorexia, constipation, depression, not being able to sleep. These are all examples of symptoms that are common across board in all of these diseases that we're talking about in varying levels, okay? So palliative care providers usually go through a thorough assessment of all of this because we know based on what we're seeing here that a lot of people with all these serious illnesses will have these symptoms in one form or the other. And sometimes they're not being addressed properly and sometimes they're impacting their quality of life. So that talks about pain, the symptoms, and the serious illness. The next thing I want us to kind of focus on is the team. As it said, it's provided by a team of specialists. And again, this is another great graphic courtesy of the Center to Advance Palliative Care that kind of looks at what the ideal, the ideal palliative care team membership should include. You have here, if we start from this corner of this graphic here, in the blue, you have the ones who focus on managing symptoms. So you have the physician, the nurse practitioner, or physician assistant in some cases, pharmacist, and the nurse, okay? So the focus there would be looking at symptoms, then looking at other things, caregiver exhaustion, because again, remember, palliative care is not just for the patient, but is also for the family or whoever that caregiver is. So part of what is done as those by the team members is kind of assessing for caregiver exhaustion. So you have questions like, how are you taking care of yourself? Who's there supporting you? Focused on the caregiver who's taking care of the patient. And usually the person who assesses that are these people here. And then it talks about the home environment. Is it safe? Is it not safe? You know, that's where you have your occupational therapist, the physical therapist, and the social worker doing that. And then now we're talking about things that impact the patient through social determinants of health, social isolation, and these are things that can be important in that scenario. Now, ideally, of course, you don't have all of these in, again, this is ideal. What you should have are the ones I've highlighted here. So the physician or the nurse practitioner, the chaplain, and the social worker, kind of focusing on not just the symptoms, but the social aspects and then the spiritual aspects of care. Now, this is what most places should have. I can tell you that from my experience in working at St. Elizabeth Hospital, this is what we tried to put in place for everybody that came through the hospital that needed a palliative care provider or palliative care consult that was referred to the palliative care team. They were seen by either the physician or the nurse practitioner. And then we had the chaplains and the social workers being involved. This is in the hospital setting. Outside of the hospital, things can be different, okay? So when we talk of the team that's involved, you can see it's multidimensional, it's multidisciplinary, kind of trying to look at different aspects of the impact of the illness on the sick person. Then we're looking at what they do. So we've looked at what the serious illness is. We've looked at what the symptoms there that are. We've looked at who's helping assess all of these things and doing all of these things. And then their role is to provide an extra layer of support. Again, here we see this gentleman who obviously looks like he has a serious illness. There's oxygen. There's somebody who looks like a nurse or a provider next to him there. And then palliative care, of course, comes in as that extra layer of support. Remember our cloak? Sorry, it looks like the Jedi or something like that. But, you know, just think of it as palliative care coming in as that extra support apart from what that person is having, okay? Now, one of the other things then we should remember is while we're talking about all of this, somebody does not have to stop the care that they're getting. Okay, so think of somebody who has a cancer diagnosis, an advanced cancer diagnosis. We've identified that this is a serious illness. We're assessing symptoms and the stress on the illness. There's a team looking out for them. They're providing that extra layer of support. The fact that palliative care is involved doesn't mean they have to stop getting treatment for their cancer. While they're getting treatment for their cancer, the palliative care team is working alongside their other doctors to provide that extra layer of support. Again, this is ideal and this is what should be happening. Okay, so it brings me to this. I got this graphic from the Journal of Palliative Medicine, no, Journal of Pain and Symptom Management, the Journal of Palliative Medicine. It's from a Canadian physician who kind of was talking about what she called the bow tie approach to integrating palliative care and disease management. If you look at that, that's what it talks about the bow tie. On the left side here of the graphic, you have the disease. And in managing the disease, again, let's say cancer, you're doing all kinds of treatment. So you're doing chemotherapy, you might be doing radiation therapy, you might be doing surgery and all of those things. And as you're doing all of that, okay, if you integrate palliative care in, what palliative care will be doing is helping with pain and symptom management, providing spiritual support, all that support. And as the disease is progressing, going from the left here to the right, the impact of managing the disease lessens and more of palliative care broadens. And what might happen is one of two things as you provide palliative care. The patient might either end up going into a rehab situation, or they might end up going into an end of life hospice kind of situation. We'll talk about that. And then at the end here, what happens is the person either survives the disease or they die, and then there's bereavement support to whoever is the caregiver that's left behind. So you're looking at two triangles that are intersecting here, the blue triangle being that associated with disease management, and the pink triangle, or whatever color you choose on your end, as palliative care. And the middle part there is where there's a lot of interaction, and then you see what happens on both ends, okay? So we've talked about this being provided along with care. And then these are the key words. Again, going back to the definition, palliative care is specialized medical care for people living with a serious illness. It is focused on providing relief from the symptoms and stress of the illness. The goal is to improve quality of life for both the patient and family. It's provided by a team, all right? It provides an extra layer of support, and it can be provided along with curative treatment. Okay, so all of what I've said right now boils down to this. The goal of palliative care is to improve the quality of life for both the patient and the family that is dealing with a serious illness. That's all this is all about. So providing the relief from the symptoms, the stress of the illness is all about improving the quality of life for both the patient and the family. So these are the things that are discussed or described as the pillars of palliative care. So all of what we've talked about, boiling it down, expert symptom management, consultation support from the primary care providers and the specialists in caring for their complex patients, skilled communication and intensive patient, family, clinician decision-making discussions, also known as family meetings, clear patient and caregiver education on what to expect in order to empower the patients to handle symptoms at home, and coordinated care and efficient transitions across settings, okay? Now, let's go back to this. How is a person getting involved or being referred to palliative care, all right? It says here palliative care is provided by the team, and we're working together with the patient's other doctors. So this is assuming that the person who has a serious illness, right, has been identified by their own primary physician as having a serious illness. And the primary physician feels, you know what, I've tried here, I've done some things, I'm not able to get a grasp on this pain that this person is having. I need to have the palliative care provider help me. Or I've started having conversations about what to expect with this patient. I'm having a tough time, I'm not getting through to them, I need somebody else to help me with that, okay? That is what ideally should happen. Sometimes it happens that way, sometimes it doesn't happen that way. Now, where does palliative care happen? If we think of the patient here, a patient with serious illness, at various points in time, this person has a primary care provider, right? So they go to their primary care provider's office who, let's say they have congestive heart failure, they go to their primary care provider, they also probably see a cardiologist. The primary care provider probably does some initial conversations, you know, you have heart failure, have you ever thought about things and stuff like that. Then maybe they end up in the hospital setting, and then ended up in the hospital setting, they come in contact with a palliative care team who sit down with them, families, to kind of talk about what's going on and address things. Maybe from the hospital, they end up going to a skilled nursing facility for rehab, Depending on the skilled nursing facility, there might be palliative care presence, there might not be. I can tell you probably a large percentage of skilled nursing facilities do not have palliative care present. Don't ask me why. It's all based on where one finds himself. If they don't go to the skilled nursing facility, or maybe they do go there and then they end up at home, sometimes people get home and you have home care because maybe they have needs that, or what you call skilled needs, and you can still get home care services. And then they still go back to see their cardiologist and the primary care provider, or the care is being provided via telemedicine, which has boomed in the last year because of everything that's going on. All right. So these are different areas in which palliative care can be provided. Does this exist in every community in the same way? No. Some communities have all, some have some. What you find in most places is there's a heavy focus on inpatient palliative care. And you don't have much of what we call the community-based palliative care, which will probably be all of this. Tele-palliative care is starting to evolve in some places, all right? So that's that. Now, the issue of palliative care and hospice, I tell people I'm a board-certified palliative care physician who works as part of a palliative care team specialized in hospice and palliative medicine, okay? Now, all of hospice is palliative care. So let's take a look at this graphic here, which I hope helps a bit. This is hospice, all right? It's embedded in the whole bucket of palliative care, all right? But not all of palliative care is hospice, all right? Unfortunately, what you see happening is a lot of people use it interchangeably, especially some of my physician colleagues, when they want to refer a patient to hospice and they don't want to make it seem like they're giving up. Oh, well, I'll have palliative care come talk to you about it, when ideally what they're saying is hospice, because the patient is getting to a point where, you know what, they need hospice. There are markers, there are predictors for certain disease entities for when somebody needs hospice. And so sometimes that there's a lot of interchangeable stuff going on with the language. But again, what I just want you to remember is hospice is a subset of palliative care, all right? It's been around longer because that's where palliative care kind of took off. But in some countries, if you go to Canada, they use both interchangeably. It's the same thing. But in the US, we use it separately just because of logistics or semantics. So kind of what are the differences? I hope this kind of helps as well. If we look at who's eligible for palliative care, like we said before, anybody who has a serious illness, right? And it's not based on prognosis. It's based on the need of the patient and the family. So are we helping with managing symptoms? Are we helping discuss the prognosis? Are we helping with making them understand what to expect on this illness? But with hospice, what you're looking at is someone who's been certified by 2 physicians as having a disease that has a prognosis of less than 6 months. So when we mean prognosis, we mean the time that someone probably has left to live. Most times we can't predict with exact certainty, but we can have a ballpark range. So someone who has a cancer diagnosis, who's been in bed for the last 2-3 months, who's having a lot of pain, who's short of breath, who's been in and out of the hospital, advanced cancer now, that person probably has a prognosis of less than 6 months and will be eligible for hospice, okay? Let's say they were diagnosed a year, 2 years ago, advanced cancer, they started going through treatment. That would have been the time to kind of incorporate palliative care discussions, helping with symptoms, discussing the possibility of hospice being appropriate somewhere down the line. In terms of the timing, again, so when is the timing for palliative care? Like we said in our definition, it's appropriate at any stage of a serious illness. You can have palliative care for prenatal conditions, geriatric conditions, perinatal conditions, okay? But hospice means that somebody has a life expectancy of 6 months or less. Here it says the median length of stay in the United States for people on hospice is 24 days. You can have, median means most people when they go on hospice, they're on hospice for 24 days. You can have as little as a few hours to as long as a year. I've seen people on hospice for about a year or two, okay? Hospice is strictly regulated now, so there's a lot that goes into that. Now, in terms of concurrent treatment, remember with palliative care, you can get that concurrently with all the appropriate treatments and services. With hospice though, the understanding is this person has a prognosis of less than 6 months. So we're not looking then at treating them anymore. So you have to stop all the treatments focused on that illness. So for cancer, they have to stop or waive curative care for the terminal illness. So chemotherapy is stopped, radiation is stopped, and all of those things, okay? Because the focus then is different with hospice. And then where do you find palliative care? Like we looked at earlier on, you can find palliative care in all those settings, but mostly it's available in the hospital setting and is now starting to grow gradually outside of the hospital setting, whereas hospice is in the community or in facilities where people are, nursing homes and things like that. Or like we talked about earlier on, you can have hospice, standalone hospice facilities, okay? So I hope this kind of helps differentiate palliative care and hospice, all right? So if your physician or physician for your loved one kind of says, you know what, I think it's time for us to think about palliative care, I would push back and say, do you mean hospice? Because sometimes they might be trying to say hospice and use the word palliative care, all right? Now, where can you find information about palliative care? There is this website that is associated with the one I talked about earlier on, the Center to Advance Palliative Care. They have a community-facing website called getpalliativecare.org. It kind of has information about providers. There's handouts for patients and families. You know, there's things about what is palliative care? Is it right for you? How do you get it? Okay. One of the links, if you go to how to get it, is if you go in there, you put in your zip code and you're trying to find, do I have palliative care available in a hospital, nursing home, office, or home? And you click search. It comes up with, and I think you can put like a distance. So let's say I put an Appleton zip code there right now, which I did, 54915, and I put a range of 25 miles. It gave me a list, and I click all of these of facilities that are related to all of these where patients have access to palliative care. And I think I heard somebody say they were from St. Paul, and I think the St. Paul Nursing Home was listed in here. Now, this is actually based on information that's fed into this directory. So as it says, the directory is published as a convenient public service and is provided for informational purposes. We regret we cannot answer individual medical questions. If you're a patient or caregiver, please contact your doctor for more information. This is based on information people have put in. So it might be helpful, at least it gives you a rough guide into what to expect. I put this here, and I was hoping we'd be able to play this. Yes, can you still see my screen?
Hi, George here, and this last chance
Okay.
at our home in Lake. We're gonna fly you. You are a bridge. It's true, or at least it's a good analogy. When you're healthy, when the bridge is sound, you can handle anything. Cars, trucks, trains, all the bumps of life, no problem. You are set. But if you're facing a serious health issue, something like kidney disease, lung disease, or cancer, the bridge starts to falter. cracks appear, and pretty soon it's hard to withstand all that traffic that includes your own medical treatment. And that's where palliative care comes in. Palliative care is a specialized form of medical care specifically designed for people with serious illnesses. Its main goal is to improve your quality of life by providing relief from the symptoms, pain, and stress that are an inevitable byproduct of both the disease and the medical intervention. In short, palliative care provides support for your bridge. And when a bridge is in trouble, there is nothing better. Now, palliative care, just like construction, is a team effort. It takes doctors, nurses, social workers, and other specialists, all working together with your physician to realize that extra layer, the layer that can make all the difference. It's a treatment method that makes sense at any stage of life and at any stage of an illness, because it's never too late to lessen the burden. So, next time someone you care about is facing a serious illness, remember this bridge analogy and be sure to consider the enormous potential of palliative care.
Again, this came from getpalliativecare.org. If you go on that website, you can watch this video. I liked it because it kind of simplifies things, and I think it kind of helps put things together. So, I'm trying to move. Oh, there we go. All right. So we're back to just wrapping up. I think we've already spent quite a bit of time already. I found this quote in an article that I was looking through earlier on today. It says, death in the modern medical community has become an adverse event, with doctors still adhering to the notion that if a patient dies, they have failed. Physicians are more likely to overtreat patients in what may be regarded as a battle to prevent or delay what is often an inevitable death. Because cure, not care, has become medicine's primary purpose, physicians have become warriors engaged in combat with the ultimate adversary, death. And in as much as this talks about physicians, I think this also applies to a lot of the patients that we deal with. You know, people are not ready to die. They're scared of dying. But what palliative care tries to do is help you prepare for that, because it's going to happen. And if it happens when you're not prepared for it, it becomes a disaster. You're leaving your loved ones with PTSD for years, which we see on this end. And so what we try to do is get people prepared for what we know is going to happen. That ends what I just have to say. I hope it's been helpful. There are a few questions that came through that I think I've tried to answer as we went along, but I'll take them again and kind of see if we have any other questions. The first question was, what is the best way to refer patients to a palliative care provider as an outpatient? And I think I kind of addressed that. I think one of the things to find out, first of all, is if you do have palliative care providers that can help you and figure out what, and I'm assuming then you already know what you're asking for. I mean, what would the need be? Are you looking for pain and symptom management? Are you looking for better discussions about what to expect? You know, it depends on what that is. If you're not getting that from your primary care provider, you can ask your primary care provider to help make a referral to a palliative care provider who can help. Realizing though that those are far and few in between, okay? I hope that answers that question. The second one, how do you see palliative care and primary caregivers working together for patients in the outpatient setting? Kind of almost the same way. The primary caregivers, oh, sorry, not primary care providers, primary caregivers. I think that's something that can happen where you have enough palliative care providers in the community to kind of help. It all depends on what the need is and what is being looked for, but definitely it goes hand in hand. If we're talking about primary care providers, I think expectation is the primary care providers kind of do the initial assessments and do the initial work of identifying what the need is and then hopefully making a referral. What we find is because we all work in different systems and one system might have one thing or the other, it varies across board. So it's ongoing work for sure. I think we talked about the differences between hospice and palliative care already. The fourth question, I know hospice can come into an assisted living facility. Are there any pitfalls to watch for, plan for when a loved one is dying in the community-based setting, an apartment in a facility? So I'm assuming this person is talking about a residential living facility of some sort. Now, this question I didn't understand because I'm not sure if the person was asking if they're dying with hospice or they're not dying without hospice, but I think let's look at it both ways. I think maybe the person is asking what are the things to look out for? If someone is dying, obviously we know that there's going to be a change in what we say the function of the person is. Someone with a serious illness, they're not as awake or lively as they used to be. They're not eating as much. They're spending a lot of time in bed. They're becoming more symptomatic. If they're in an assisted living facility, obviously it makes sense to have hospice coming in. I don't see any reason why hospice cannot come in. In that kind of situation, sometimes one of the things one can plan for if you're going to get hospice involved is, one, can they stay then in the assisted living facility? Because most times when people are in assisted living facilities, it's assisted. So the person has their apartment and hospice comes in, but you might need to plan for getting maybe 24/7 care outside of what hospice provides because hospice is not going to be there 24/7. Or maybe looking at moving them from an assisted living facility then into a nursing home where there's probably more supervision because there's not as much supervision in the assisted living facility. So there might be a need to plan for moving them from the assisted living facility into a nursing home and then bringing hospice in addition. I hope that kind of helps answer that question. Do I have any suggestions to work with other provider systems to improve advanced care planning discussions and use of palliative care properly for our patients? I think that will be addressed in the next session by John Maycroft next month. I think that's a whole different topic on its own entirely. But I think it's a matter of identifying what those needs are. And one of the things I think also is because advanced care planning is way much more than what palliative care needs to do, it should be broadened beyond the scope of what palliative care providers should be doing. I think this is something that healthcare systems need to take on one way or the other. Unfortunately, I think a lot of places struggle with this, probably because of the cost of what it entails. And I think that's why we have the Fox Valley Advanced Care Planning Partnership, providing a lot of work in the community setting to kind of help put appropriate structures in place. The Faith Ambassador Program is an example, all those kinds of things. But it's a partnership. It's going to be involved community partnerships to get things done appropriately. And I think the last question, who refers a patient to hospice care, the general practitioner or palliative care? Another great question. Anybody can make a referral to hospice. If you see your loved one and you think they need hospice, you can ask the primary care provider for a hospice referral or a hospice evaluation, depending on where the person is. If the person is at home, most times hospice can come, pay a visit, look at the person, assess them, and determine, yes, this person meets hospice criteria. But of course, sometimes they would need records from the primary care provider. What happens that I see sometimes is we have people who have their loved ones in facilities, and the facility is seeing signs that this person would need hospice. They bring it up with patients and families, and everybody's afraid and scared. And it's like, oh, no, 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 no. And unfortunately, it doesn't end too well. They end up in the hospital and things like that. But anybody can make a referral to hospice, all right? At least for an evaluation at least. So that's that there. I know I went through a whole lot of things and didn't leave room to ask questions, but if there are any questions right now, I can take that. I hope this was helpful.
looks like we do have an, oh, no, she said, thank you for answering the question. Yeah. It looks like you got through most of the questions. Yeah. So I think we can call it there. So that will do it for this month's iteration of our Let's Talk series. I just want to say thank you to Dr. Adeboye for his excellent presentation. For those of you, if you missed any part of this presentation, or want to see any of our other previous work and content and similar videos, they will be uploaded to YouTube as well as our Facebook page and our website as well, that you'll be able to consume this at any time you'd like. For more information on other events, monthly classes, future Let's Talk series events, as well as resources like getpalliativecare.org and CAPC, you can go to our website at FAAHPM.org, or also like us and follow us on Facebook at Let's Talk Fox Valley, as well as on Instagram. Also, please be sure to check your email after this, as we will send out a survey just for an evaluation for us, so we can see where we want to take this series as we move forward. So I just wanted to say thank you again to everyone attending, as well as Dr. Adeboye for this excellent presentation. So thank you for being with us today. We look forward to seeing all of you again, hopefully next month on August 11th at 5 p.m. with John Maycroft of Maycroft Advanced Care Planning Services. So thank you, everyone, once again. Take care and good night.
Thank you, Josh. Thank you, Ellen. Thank you, everyone, for coming. Have a good evening.